Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 514 of our pharmacotherapy series, which majors in chronic kidney disease. The first case reads, WKS is a 24-year-old Hispanic woman who has an 18-year history of type 1 diabetes mellitus with complications of diabetic nephropathy, retinopathy, and neuropathy. She was diagnosed with CKD 2 years ago. She started peritoneal dialysis at that time. Her current medications include metoclopramide, marketed as Reglan, 10 mg thrice daily before meals, insulin aspart 10 units with meals, insulin glargine 25 units nightly, Doc-U set 100 mg every day, calcium acetate 2001 mg orally thrice daily with meals, erythropoietin 5000 units IV twice weekly, iron sucrose 100 mg IV 3 times a week, paracalcitol 4 micrograms IV 3 times weekly, and nephrocaps 1 capsule every day. At a recent clinic visit, findings on physical examination included a blood pressure of 128 diastolic 84 systolic, diabetic retinopathic changes with laser scars bilaterally, and diminished sensation bilaterally below the knees. She has normal serum electrolytes. Her random blood glucose is 250 mg per deciliter. Her BUN is 45 mg per deciliter. Her serum creatinine is 8.9 mg per deciliter. Her hemoglobin is 10 grams per deciliter. She has a WBC count of 6,200 per microliter. Her calcium levels are 10.2 mg per deciliter. Her phosphate levels are 6.8 mg per deciliter. Her intact parathyroid hormone, abbreviated as IPTH, is 950 picograms per milliliter. She has a thyroid-stimulating hormone level of 5 million international units per liter. Her total serum protein is 5 grams per deciliter. She has a serum albumin of 3.1 grams per deciliter. Her uric acid levels are 8.9 milligrams per deciliter. So my first question to you is, describe the etiology of WKS's abnormal bone, calcium, phosphorus, and parathyroid hormone, abbreviated as PTH, findings. I will first focus on the etiology. Mineral and bone disorder of CKD, abbreviated as CKD-MBD, is the term used to collectively describe the mineral, e.g., phosphorus, calcium, and PTH, bone, osteodystrophy, and soft tissue calcification abnormalities that develop as a complication of CKD. The older collective term of renal osteodystrophy failed to adequately illustrate the broader clinical complications associated with the biomarker abnormalities and calcification, and is now only used to describe, specifically, the bone pathology. Hyperphosphatemia, hypercalcemia, hyperparathyroidism, decreased production of active vitamin D, and resistance to vitamin D therapy are all frequent problems in CKD that can lead to the secondary complications of mineral and bone disorder of CKD. Although the interrelationships among phosphorus, calcium, vitamin D, and PTH have been reviewed extensively, fibroblast growth factor 23, abbreviated as FGF23, a phosphaturic hormone, has added some new insight. Increased dietary phosphorus intake stimulates fibroblast growth factor 23 secretion. Fibroblast growth factor 23 increases phosphorus excretion via the proximal tubules, inhibits vitamin D activation, increases activated vitamin D catabolism, and is associated with kidney disease progression. At a GFR above 30 ml per minute per 1.73 meters squared, elevations in fibroblast growth factor 23 and PTH maintain normal serum phosphorus. This concept is referred to as the trade-off hypothesis, where the ability to maintain normal phosphorus concentrations occurs at the expense of developing secondary hyperparathyroidism, abbreviated as SHPT, the excessive secretion of PTH and elevated fibroblast growth factor 23. However, fibroblast growth factor 23 is not currently measured in the clinical setting. Clinically significant increases in serum phosphorus, or frank hyperphosphatemia, typically are not seen until late stages of CKD, GFR below 30 ml per minute per 1.73 meters squared, when compensatory mechanisms within the kidney are compromised. The kidney is the principal organ responsible for systemic vitamin D production, and, as such, vitamin D metabolism is altered in the presence of uremia. Persistent hyperphosphatemia stimulates the release of excessive fibroblast growth factor 23, which inhibits the normal conversion of 25-hydroxyvitamin D3 to its biologically active metabolite, 1,25-dihydroxyvitamin D3, by the enzyme 1-alpha-hydroxylase. This enzyme is present in proximal tubular cells of the kidney and is necessary for conversion of vitamin D to the active form. This active form of vitamin D, also known as calcitriol, increases gut absorption of calcium and interacts with vitamin D receptors on the parathyroid gland to suppress parathyroid hormone release. As a result of decreased calcitriol production, the absorption of dietary calcium in the gut is diminished. Decreased suppression of parathyroid hormone release by vitamin D in conjunction with hypercalcemia promotes continued stimulus for mobilization of calcium from bone. Furthermore, uremic patients require a higher extracellular calcium concentration to suppress secretion of parathyroid hormone. This is also described as an increase in the calcium set point, or the concentration of calcium required to inhibit 50% of maximal parathyroid hormone secretion. The chronic effects of hyperparathyroidism on the skeleton lead to bone pain, fractures, and myopathy. In children, these effects may be particularly severe and usually retard growth. The metabolic acidosis of kidney disease also contributes to a negative calcium balance in the bone. Patient WKS's presentation is consistent with chronic kidney disease mineral bone disorder, abbreviated as CKD-MBD, based on the observed changes in bone architecture and abnormalities in serum phosphorus, calcium, and parathyroid hormone, all can be attributed to her kidney disease. Vitamin D levels, i.e., 25-hydroxyvitamin D, should be checked in CKD3. Insufficient, that is less than 30 nanograms per milliliter, and deficient, that is less than 15 nanograms per milliliter, vitamin D levels are prevalent in the majority of CKD and end-stage renal disease patients. Several studies have linked depressed vitamin D levels to increased vascular calcification, cardiovascular disease, and mortality. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 515.